This is about retinoblastoma. Next is that's eye, so we call it. Okay, this is the retinoblastoma tumor. You can see it in the retina. This is the tumor. Okay. We have discussed all the questions of retinoblastoma already, so we can move further. This is in this showing you you remember the pathology? 2 points I had taught you, calcification and necrosis. So this is the intraocular calcification. Typical feature of retinitis pigmentosa. This year's exam question 2012, what is the triad of RP, right? पूरा ट्रायड मेंशन था, आपसे डायग्नोसिस पूछा गया था और उसमें आपको आरपी ना देके लिखा था रेटिनल डिस्ट्रॉफी. सो आई होप यू ऑल आर वेरी क्लियर. रेटिनाइटिस पिगमेंटोसा इज डिस्ट्रॉफी ऑफ व्हाट? rods and cones. So retinitis pigmentosa is dystrophy of rods and cones. Okay. Then what is dystrophy of retinal pigment epithelium known as? Best disease. What is the full form of Best? Pura bolo. Best vitelliform dystrophy. Best vitelliform adults में होता है कि बच्चों में? Vitelliform best disease is for childhood. Okay, this is a childhood disease. Autosomal dominant or recessive? Dominant. And what about electrooculogram in Best disease? Normal or abnormal? Abnormal. Okay. And what are the questions asked from retinitis pigmentosa? Retinitis pigmentosa से आपसे पूछता है ना, what is the most common seismic association of RP? Ushers. What is ushers? RP with deafness. Okay. What is IK with deafness known as? IK matlab interstitial keratitis with deafness. You just told me RP with deafness is ushers. I am asking what is IK with deafness? Cogan syndrome पढ़ाया हुआ है मैंने. COGAN. Cogan syndrome. Causes of interstitial keratitis में बताया था. So that is Cogan syndrome. Okay. Coming to this one. इसके triad पे सवाल आता है. Then yes. What is the field effect in early case of RP and what is the field effect in late case? Early case पहले बताओ. Ring scotoma. Late case? Tubular vision के causes? Apart from this one? You will not answer glaucoma. That's what I wanted to correct you. Do you remember I taught you that glaucoma may, at the end, just before blindness, central and temporal island of vision is left behind. So it cannot be a purely tubular vision because a temporal island of vision is also there. And which one stays till last? Temporal. So it is not a tubular vision. So another cause of tubular vision is quinine toxicity. Very good. Okay. Suddenly I remember one more question. अच्छा चलो slide पे जाएंगे तो बात करेंगे. ठीक है. So these are the questions. Okay, yes. One more thing. Retinitis pigmentosa. What is the most common mode of inheritance? Exam question. No, it is AD. I had seen it in your Facebook because you all have written AR. Why AR? I corrected it there itself. It is autosomal dominant, not recessive. Most common mode of presentation is AD and AD also has the best prognosis. It has the best prognosis. Okay? Okay, but if they ask you, suppose the question is, most commonly it is hereditary or non-hereditary? Non-hereditary. So most commonly RP is sporadic or non-hereditary. Agar hereditary hota hai, then the most common mode is this one, AD. Okay, next slide. ROP, you remember demarcation line? This is the demarcation line of stage 1 ROP separating the hypoxic part from the normal retina. This is your demarcation line. ठीक है? ROP से 4 सवालों का जवाब दीजिए मुझे. First question is, which factor is more important? Low birth weight or prematurity? Okay. Second question, so the answer is prematurity. Second question, what is the ideal age to screen the child? Between 32 to 36 weeks. Why? Before 32 weeks, it is impossible to see the retina. Pehli baat. Pupil never dilates. There is a tissue behind the pupil, which is called tunica vasculosa lentis. So you can't see the fundus before 32 weeks. And after 36 weeks, we don't expect an ROP. Okay? Teesra sawal. What is the treatment of ROP? Pardon? Yes, please don't answer PRP. We don't do a pan-retinal in a small child. We will just laser this hypoxic retina, this part, this hypoxic retina. Okay? Okay, the fourth question I forgot. The fourth question of ROP is about what is the threshold disease? What is the criteria of defining threshold disease? Okay, I'll just mention one. एक heading में बताओ. Which stage? 3 and above. Stage 3 and above. Which zone? 1 and 2. Very good. What extent? Very good. 5 contiguous glaucas or 8 non-contiguous. Along with plus disease. Unless and until all the four criteria are fulfilled, we will not start the treatment. और सिंपल सा रीजन ये है, अननेसेसरी इतने छोटे बच्चे में लेजर बर्न नहीं देंगे, क्योंकि बहुत से केसेस दे रिग्रेस बाय इट्स ओन. You don't have to interfere. So unless it fits into the threshold disease, please don't start the treatment in the child. Because ultimately laser is a burn only. These are all laser burns. So this is a diagrammatic representation that this is the avascular retina, this is the vascularized, this is the demarcation line. And when it is elevated, this is your ridge formation, stage 2. Okay, this is your wet ARMD. It's a neovascular membrane at the macula. I hope you all are clear. ARMD is a retinal disease or choroidal disease? It's a choroidal disease. Okay? This is how a fluorescein angiography looks. So can you realize how nicely we can see any leakage, any block? अगर किसी artery में, किसी capillary में नहीं पहुंचेगा fluorescein, that means it is blocked. Here, can you see this leakage? This is the leakage. Which type of leakage this is? Yes, it's an ink blot appearance. There are two appearances in CSR. This is ink blot appearance. And I have told you just now that it's a breaking of which barrier? Outer blood retinal barrier. Diabetic retinopathy, so many features, just pay attention on the slide. These are the soft exudates, these are the flame-shaped hemorrhage, again a soft exudate. And these small जो yellow colored दिख रहे हैं, ये सब hard exudates. ये हो गया flame-shaped hemorrhage. This is a blot and small ones are dot. And this is a large blot hemorrhage. And at the tip of the capillaries, अब यहाँ पे दिख रहा है ये. These are microaneurysms. Actually, the diagnosis of microaneurysm you can only make when you do a fluorescein angiography to differentiate it from hemorrhage है कि aneurysm है. Anyway, so because it's a large blot hemorrhage here, so much, this is the macular area which is edematous. I would say this is a case of pre-proliferative DR. I don't see any new blood vessel, so I cannot say it is a proliferative DR, but it is definitely a severe NPDR. Mild, moderate, severe बताया था ना? जिनको नहीं बताया था, I'm telling you now. I had told you that DR is divided into 3 stages: BDR, pre-proliferative and proliferative. Another way of dividing it is NPDR, mild, moderate, severe, and then PDR. NPDR, mild is only microaneurysm. Moderate is all the feature of BDR. And severe is pre-proliferative. Okay. This is lattice. Where do you see lattice degeneration? Where do we see lattice degeneration? Pathological myopia. What is another degeneration which causes hole formation? Very good. Snail track degeneration. Okay? Okay, pathological myopia, there are a few more questions. What are the other features asked? Foster-Fuchs spots seen at the macula. Posterior staphyloma, again they will ask you. And any lattice can lead to what? Rhegmatogenous retinal detachment. Very good. This is sauce and cheese. Can you see this? It so much justifies the description. This is your sauce and cheese retinopathy. This one is the necrosis and this is your hemorrhage. Okay? What are these? एक मिनट एक चीज और बताओ. What is the most common ocular manifestation of HIV? आपने क्या बताया था? Microangiopathy. And which is the most common opportunist infection of HIV? CMV. Okay. Then coming to this. These are the drusen's of dry ARMD. 2 features पढ़ा था ना हमने? drusen and geographical atrophy. So this is the feature of dry RMD. Okay? Drusens. They are nothing but dried up deposits. This is your RD. Can you see the gray reflex? This is attached retina, this is detached retina. And there is a nice line you can actually differentiate. So this is your retinal detachment. What are the types of retinal detachment we know? Tractional, rhegmatogenous and exudative. Okay. Very good. What are floaters? Opacity where? What will the patient complain? Something, object is moving in front of the eye. Some of you, many of you, even me, if I see in the clear sky, I can see objects. So don't panic. It is normal also. Those collagen fibrils also you can see in the vitreous as floating in front of your eyes. Okay, but all of you who can see floaters should get an indirect ophthalmoscopy done and confirm that everything is fine. Okay? Acha, what is syncytial scintillans composed of? Syncytial scintillans, vitreous के chapter में मैंने पढ़ाया था. It is a type of floater. What is it composed of? Okay, you two guys are talking too much. What are syncytial scintillans composed of? You want me to come there? Of course you know that you all are talking. Okay, it is composed of cholesterol bodies. ठीक है? और फिर पूछता है what is asteroid bodies composed of? Asteroid bodies are composed of calcium and lipids. Calcium and lipids. What is musky volitens? These are all questions from vitreous I am suddenly revising with you all. Musky volitan is remnant of hyaloid tissue. It is a remnant of hyaloid tissue. And what do you mean by hyaloid tissue? Hyaloid tissue is primary vitreous. Okay, this is your cherry CRAO with a cherry red spot, edematous retina. This is what is CRAO. Okay, CRAO में एक important thing. A person has suffered from CRAO but he is still not blind. When can that happen? See, 14% of the world population has got a dual blood supply at the macula. One is the central retinal artery and the second one is the cilio-retinal artery. So if cilio-retinal artery is also supplying the macula, this patient will preserve, the central vision in this patient is preserved along with some small field. That is tubular vision. So again another cause of tubular vision is a patient of CRAO with cilio-retinal artery will have a tubular vision. Okay, the question they have asked you that cilio-retinal artery is a branch of? Cilio-retinal artery is a branch of? You will answer short posterior ciliary artery. You remember I taught you outer 4 layer, short posterior ciliary, inner 6 layer, central retinal. So cilio-retinal is a branch of short posterior ciliary artery. What is this slide? Splash sauce appearance. पढ़ा है ना अभी बताया था आपने. CRVO. These are the multiple flame shaped hemorrhage around the disc. Another question from CRVO. Anyone? What is the other question they ask you apart from splash sauce appearance? 100-day glaucoma. Also called 90-day glaucoma. Right? That is nothing but neovascular glaucoma in patients of CRVO. Hypertensive retinopathy. These are, if you look at so many soft exudates. So it cannot be normal hypertensive retinopathy. It's a malignant hypertension with hemorrhages and so many soft exudates. Okay. HR से जो सवाल आता है वो ये आता है, a patient of preeclampsia or PIH, how will she present in the eye? What is the ocular finding of PIH? That you will answer HR, hypertensive retinopathy. Can you see this? Mushroom shaped manner leakage. This is your smokestack appearance of CSR. CSR is a disease of which age group? Young males. What is the treatment of CSR? It is self-limiting. Okay. Primary optic atrophy. It was your 2012 exam question. Listen to me. Half of the disc is developing a chalky white with a clear disc margin, but the other half is normal. It still has got its color. So you can compare. This is the normal color and this is becoming pale. This is primary optic atrophy, which is still not total. What are the other types of optic atrophy you know apart from primary? Secondary, consecutive. Consecutive is due to retinitis pigmentosa. It is due to retinal disease. And of course, glaucomatous. This is papilloedema. Can you see this? This is the blood disc margin, raised disc, and these are the dilated veins. Venous congestion itna zyada hai, almost you can feel the disc being raised. It is so edematous, it has to be papilloedema. And can you realize there is no disc margin we can appreciate? Papilloedema questions we have already discussed. What is this now? You will tell me. Pardon? Flower petal pattern. Flower petal pattern is a feature. This is the leakage in a flower petal pattern. It is a feature of which barrier is broken? Inner blood retinal barrier. These are the laser burns. Can you see this? These are the laser burns. So it is not a pathology. When you do PRP, you actually leave the macular area and you involve the rest of the area. Okay? So this is pan-retinal photocoagulative laser burns. How many burns you give in PRP? 2000 to 2500 burns total. So that's it for slides. I would like you all to look at the slides and revise it again. This is PRP. Very good. Papilloedema, primary optic atrophy, smokestack, hypertensive, splash sauce, CRU. So what you can see here is cherry red spot and edema, RD, drusense, sauce and cheese, lattice, pre-proliferative DR. I hope you all are clear about what is what. This is flame shape, soft exudates. ये large blot hemorrhage है, ये छोटे वाले yellow, these are hard exudates. This is your smokestack. Oh, sorry, ink blot. Very sorry. This is your ink blot. We are over with the smokestack. This is your wet ARMD. That is the neovascular membrane. Ridge formation, demarcation, demarcation. Typical. And can you see this? The bony spicules, these pigmentary disturbances, they are involving the mid-peripheral retina, which shows you that, okay, when you say attenuation of arteries, what is the normal AV ratio? What is the normal AV ratio? 2:3. And be careful, they are asking you AV ratio or VA ratio. उसमें भी गड़बड़ हो जाती है. Okay? So, AV ratio is 2:3. 2:3, normal. Okay, this is your intraocular calcification, which I had shown. Okay? Retinoblastoma. Finish with that. No, this is I'm showing only the attenuation. This is an attenuated artery. हमेशा जो thicker वाली है वो vein है, और ये जो पतली वाली artery. Normal it is 2:3. For example, you see in this papilloedema. How do I know that the vein is? See, this is the. ये देखो, ये vein है, ये artery है, ये normal है. This is 2, this is 3. This is the normal ratio. Now if you see this papilloedema, here. Can you see the ratio? This is the vein, ये वाली artery है. So the ratio is more than that. Now it is not 2:3, it is 2:4 or something. So normal, जब तक आपको ratio नहीं पता होगा, आप कैसे बताओगे कि attenuation है या dilatation है? So that is it. And here in this case, if you look at retinitis pigmentosa, you can see the attenuation. ये attenuated है, artery काफी thin है. Normal मैंने ये दिखाया आपको, देखिए, ये. See the artery here. And now see the artery here. Look here. Can you see this? So this is the difference. Is it clear? Clear? Okay. This is intraocular calcification, retinoblastoma, leukocoria, sty, Tylosis, Calagion, Entropion, Ectropion, Ptosis, Capes, distension of the sac and the stone, again normal DCG, follicles, pits, arch line, Cobble-stone, flectanular, Pterygium, membranous, band shape, Keratoconus, arcus analis. Again, can you see this? Nasal shifting of vessel, thinning of the neuroretinal rim, 0.7 cupping. Again, 0.7 cupping with, this one is your laminar dot sign. Laminar dot sign. This was your Vossius ring, Snow-flake, lamellar, subluxation of lens, Rossette and sunflower. That's it. Thank you so much. Hanji. Of course, there are many questions which are not very clear cut. But what was given in that question, the history was injury by a vegetative matter. Got it? Injury by a vegetative matter can never be due to acanthamoeba. So we will have to stick to that, and then we will answer the question as fungi. Yes. Okay? Yeah. Any other question, please? Yes?
Ma'am, artery not supplying the retina.
Where are you? Either.
Artery not supplying the retina.
Yeah, that question is again the silliest question I have ever heard of. I'm so sorry to say that. The question was, what she is referring is, all are the blood supply of retina except, and the options were ciliary artery, central retinal artery, circle of Hallerens in retinal arteries. This is the same question referring now? Okay, what to do now? So by exclusion, we mark the answer as retinal arteries. Reason being, outer four layer of retina is supplied by short posterior ciliary artery. Okay? Choroid को भी यही supply करती है. Outer four layer of retina को भी यही करती है. Inner sixth layer of the retina is supplied by central retinal artery. ठीक? And the anastomosis between these two is called circle of Hallerens in, which supplies the area around the optic disc. So we are left with no other option as but retinal arteries. Okay? Yeah. Yeah. Just you remember Arnold-Chiari malformations. Downbeat nystagmus says when the fast phase is downwards, it occurs in the lesions of foramen magnum. Ho gaya. So you will answer Arnold-Chiari malformations. जोर से बोलो. Yeah. I have given you this test question, where all are the causes except one, so you can learn all those causes also. That's what you're asking. Yeah. But mostly what they ask you as a leading question is Arnold-Chiari. That was just a difficult form of the question. They will not ask you.
Excuse me, ma'am. Ma'am, difference between INO and 1.5 eye syndrome.
1.5 syndrome is जब एक side का, from one side both PPRF and MLF are gone. Okay, let's see. You remember, you know how the horizontal gaze is managed? PPRF is the boss. It contracts the lateral rectus of its side. Suppose I have to look to the right. So PPRF is ordering my right lateral rectus. For my left medial, it orders the MLF and MLF orders the MR. You know this. Okay. If one-sided, suppose right PPRF and right MLF, both are gone. What is happening? Right side no abduction, PPRF is gone, no abduction. Right का MLF भी चला गया, उसका no adduction. But right का PPRF left के MLF को भी manage कर रहा है ना? So no adduction here, and adduction and abduction both are absent here. So it becomes 1.5. Okay? So 1.5 is nothing but when PPRF and MLF of the same side are damaged. Yes. Oculogyric crisis occurs in mainly it's an idiosyncratic reaction to the drug where there is a conjugate movement of the eyes along with the head movement. That's called oculogyric crisis. Okay? It's mainly an idiosyncratic reaction. Just check which drug. Most probably phenotherapy. I have to confirm.
Spot, Nyman peak or GM1?
See, this is second one. What you said?
GM1 gangliosidosis.
GN1 तो ठीक बोला. पहला क्या ऑप्शन बोला?
Nyman peak.
हाँ?
Nyman peak
तो होता ही होता है. उसमें तो कोई confusion ही नहीं था.
Ma'am, Nyman peak 4 stages, only one first stage is found, and GM gangliosis.
Actually, see, I'll tell you. This is one question which is genuinely very confusing. Okay?
Yes, ma'am.
Because I have explained you why cherry red spot occurs. It is due to deposition in the ganglion cell layer. So all the deposition should cause it, right? Some books say something, some books say something. I follow Yanoff. I consider it the boss. So what Yanoff is saying, Gauchers में भी होता है, Niemann-Pick में भी होता है, Tay-Sachs में. नहीं, Niemann-Pick में तो है. I told you ना, cherry red trees never grow tall. उसके तो पूरे mnemonic में है Niemann-Pick में. But what is I'm saying you, telling you is that Yanoff says, according to Yanoff, GM1 gangliosidosis is of two types, type 1 and type 2. Type 2 has cherry red spot, type 1 may not present as cherry red spot. ठीक है? So, I'm telling you another thing very honestly, that in one place I have also read that 50% of type 1 may present. So ultimately all the four options become correct. But in our situation, to answer that question, please answer GM1 gangliosidosis, because according to Yanoff, Gauchers में भी होता है, Tay-Sachs में होता है, Niemann-Pick में होता है. We are not left with any other option. Am I clear?
Yes, ma'am.
Yeah.
Ma'am, in retinoblastoma,
Yes,
ma'am, osteosarcoma is the most common hereditary association. But the sporadic cases are most common, about 70%.
Yes.
And the hereditary cases are nearly 30 to 35%.
Okay.
And question is most common association with retinoblastoma. Is it not pinealoblastoma?
Most common?
Ocular association.
Ocular association, non-ocular malignancy you're asking, or you're asking the hereditary, your question is not clear. Most common ocular, retinoblastoma itself is an ocular disease.
Most common non-ocular association.
Most common non-ocular malignancy, you will always answer osteogenic sarcoma, whether he has hereditary or non-hereditary. All these cases are actually hereditary.
Ma'am, one...
Pinealoma भी hereditary association होता है, osteogenic sarcoma भी hereditary association है. I have researched on it, and pinealomas are these days very rare. So we will mark the answer as osteogenic sarcoma only. ठीक है? और पूछो.
Thank you, ma'am.
हो गया? Yeah.
चलेजियन सर्जरी में जो इंसिजन लगाना है.
Raise your hand. Let me see you also. कहाँ से? हाँ बोलो.
मैम, चलेजियन सर्जरी में जो इंसिजन लगाना है, वर्टिकल या हॉरिजॉन्टल, अगर दोनों ऑप्शन में है तो?
It should always be vertical. Okay? Yeah. And it is called chalazion. Right? Good. Yeah. Pilocarpine नहीं होता, pilocarpine होता है. Retina नहीं होता, retina होता है. ठीक है? Okay, these are some of the common pronunciation problems. Anything else? Dilatation of veins. The answer is dilatation of veins. Okay? Yeah. सीधा बैठो, sit straight. Yeah. ALL. Children में ALL common होता है. Then you have to see the language of the question. Most common metastatic tumor in the children is neuroblastoma. Option होगा तब देखी जाएगी वो. ठीक है? What happens? Single question, they change the option so many times to make it 5 questions, so that you have so many questions. But it only causes confusion. Most common metastatic tumor पूछेगा तब neuroblastoma बोलना. Children में. Yeah. Yes. Which one? I'll just check it if there is any. I think your pediatrician people will tell you more better. But still, I'll check this. Generally, it is in this our eye book. It is generally not written like this. कि नहीं ये nasally होगा या वो होगा. It's a dryness. It can occur. I think Bitot spot is more temporally, but clinically, if I think, I don't know. I'm really not sure of that. I'll check it and mail you. You just mail me this question. Okay. No यार, Bitot spot is associated with अच्छा fat malabsorption syndrome तो हो ही सकता है. Any malabsorption और ये protein vitamin A xerophthalmia हो जाएगा. I think this should be nasally or temporally. जब देखो तुम लोग क्या करते हो? The question was something else, but you put the question to me like this. What it is there, nasally or temporally, which nobody asked. So that's why it's not in my mind. It is not specifically given in the textbook. इधर ही होता है. So don't put the question this way. Give me the correct question so that I can answer.
And the question is like this: true about bite-out spots.
Yeah.
It is present nasally. It is associated with fat malabsorption.
Okay.
And the third option is it is associated with pinguela.
I think fourth was insignificant.
Yes, ma'am.
Pinguicula बुलाते हैं उसको.
Yes, ma'am. Pinguela.
It's okay. It's fat malabsorption लिखेंगे हम लोग आंसर. क्योंकि मुझे जो I don't think कि ऐसा कुछ है कि nasally, temporally, nasally. Yeah, temporally ज़्यादा होता है most probably. Which I clinically remember. हाँ बताइए.
मैम यहाँ पे.
Where are you?
यहाँ पे. मैडम bilateral proptosis in children's actually chloromo होगा या ALL?
It is ALL. In that question, the original question of your exam, the answer is ALL. Okay? No confusions.
Ma'am.
It's very difficult to say. Huh?
Ma'am, in ophthalmology.
Metastasis bolo. The question that you're asking. Adults, most common cause of any proptosis in adults, first you should always say thyroid. Proptosis in adults, whether unilateral, bilateral, painful, painless, whatever it says, most common cause is always thyroid.
I mean, bilateral cause of proptosis in children is ALL.
I told that, yes.
And unilateral?
What?
Unilateral proptosis.
Unilateral proptosis ka what? Most common cause. Most common cause of which is the tumor? Which is the most common tumor of कोई intraorbital tumor ही proptosis cause करेगा ना?
I mean, book it was written dermoid cyst or capillary hemangioma.
These were the two confusions. Rhabdomyosarcomas was not mentioned. Then you mark dermoid cyst. Okay? Yeah.
Ma'am. Ma'am.
Where?
Ma'am, yeah. Ma'am, in ophthalmosis due to paralysis of orbitalis or LPS?
I told you. In the morning, you came late?
Yes, ma'am.
Okay. Orbitalis is a vestigial muscle. It is not mentioned in the eye books. I have searched it. It's an internet material only. I even talked to surgeons, all my colleagues, whether they're dissecting in the plastic surgery, whether they know what is orbitalis. Even they don't know what is orbitalis. So it's a vestigial muscle. Let's not give it any importance. Even in your neurosurgery books, this is given that Horner's syndrome में जो भी in ophthalmos है वो apparent है. अच्छा, the question that you're asking is about LPS. That's in ophthalmos is due to whether it is LPS or orbitalis, right? You will answer LPS. It is a pseudo in ophthalmos. Okay? Yeah. Hanji. You have to do it. HW है. कुछ HW खुद करने पड़ेंगे. मैम से पूछने से नहीं होता. I have given the names, only learn the names. 3 names of act, 3 names of end. आपके हाथ में दिया गया है, खोल के बस पढ़ना है. Okay? Do it. Anything else? हाँ जी बोलो. वो पूछ रही है उसको बोलो.
Ma'am, diplopia in all direction, myasthenia gravis or sixth nerve palsy?
Myasthenia. Any nerve palsy means muscle is gone. Muscle, जो भी muscle जाएगी, diplopia will always be in the direction of the action of that muscle, not in all directions. Okay? Yeah. It is always a feature of paralytic squint. There is nothing called aparalytic. It is either concomitant or paralytic. You said a paralytic squint. That's what you said? Yes. Yeah. It is a feature of paralytic squint. What are the other causes of binocular diplopia apart? This was also an HW, but you all are not reading it. What are the other causes of binocular diplopia? No? कुछ और बताओ. Binocular diplopia क्या cause बताओ और? Thyroid ophthalmopathy. Restrictive causes याद करो. Blowout fractures. They are all causes of binocular diplopia. And what are the causes of uniocular diplopia? Subluxation of lens के आगे पढ़ा कि नहीं? नहीं पढ़ा. Subluxation of lens, intumescent cataract में याद है? Polyopia मिलता है. Then polychoria, where there is multiple pupil. That is also a cause of uniocular diplopia. ठीक है? Learn the causes, learn that causes.
Ma'am.
हाँ, yes,
Ma'am, before surgery, which question था मैम? Before surgery.
पार्ट प्रिपरेशन के बिना सर्जरी करोगे तो इन्फेक्शन हो जाएगा, यही क्वेश्चन है ना?
नहीं मैम.
अच्छा.
Before surgery, gonioscopy lens used. Which gonioscopic lens is used? Zeiss था ऑप्शन में, Cope था, और मैम दो याद नहीं. Goldman और एक और.
Mail me the question, please.
Yes ma'am.
Mail me the question.
Excuse me, ma'am.
ठीक है? Just mail me the whole question.
Ma'am.
You all know my mail address? All of you know my mail address? It is drruchirai@rediffmail.com. All in small, no gap.
Excuse me, ma'am. Ma'am,
Yes.
after what interpupillary distance will you call it hypertelorism?
What is actually IPD का कोई definite value इसलिए नहीं है, because if we take the IPD values of all of us sitting in this auditorium, it is everything will be variable. It can range from anything from 57 millimeter to more than 60 millimeters. So they have not given any criteria like this exactly. But if I find the criteria, I'll mail you. Just give this question back to me. Okay? Yeah. Because IPD is a very, very variable value. और देखो हाइपरटेलरिज्म में देखते ही समझ आ जाता है, ब्रॉड नेजल ब्रिज है, दैट इज मेनली जितने भी हम ऑर्बिटल मालफॉर्मेशंस पढ़ते हैं ना, क्राउजन सिंड्रोम, एपर्ट सिंड्रोम, उसमें मिलता है हाइपरटेलरिज्म. ओके, या स्टॉप. ओके, ओके, थैंक यू एंड ऑल द बेस्ट, स्टडी हार्ड. ओके.